Now I request Dr. Shishir Agarwal sir to come.
Good afternoon, everybody. So non-healing fungal corneal ulcers effectively treated by carbolic acid cauterization. So corneal ulcers, fungal corneal ulcers, these are pretty common in North India in the agricultural belt. Like we have a center in Meerut, UP and Delhi. So we encounter history of vegetative trauma, and thereafter fungal corneal ulcers are found very commonly. We examine the patient and we conclude whether it is bacterial, fungal, viral or mixed as per diagnosis by microbiology, and clinically we give medication. Sometimes it responds, and big ulcers sometimes they don't respond, and we revisit our diagnosis and tailor the treatment accordingly. The ulcer, if it does not respond, it gets deeper, finally perforates. We see for other measures, finally a therapeutic PK is required. So non-responding corneal ulcers and those which are rapidly spreading. So it's a very old method of chemical cauterization by pure carbolic acid, which is very effective. We've seen, I'll just demonstrate it. So these are the bad ulcers. You've tried the antifungals, the topical and oral, and these are not responding. So you do a good chemical cauterization by pure carbolic acid. It is done under topical. You put a speculum, you take a matchstick, and that is just made pointed, and you dip it in pure carbolic acid, and this is put onto the cornea, and nothing will happen to the cornea. It penetrates a little into the corneal substance but does not penetrate deep. Betadine and other things, they actually don't penetrate at all. So the edges are removed, the undermining is removed, and so the pathogen is exposed and is killed by the carbolic, and you do a good thorough cauterization. That is the most important thing. You devote a little time, and even if it goes to the little beyond the ulcer margins, it does not matter. It will whiten a little, and then finally it will all, and it's very helpful in healing. So we've lost this thing, and it is actually very effective once the other things are not, it is not responding to the other things. So we do it very commonly, and most of the ulcers will heal, which are not healing by topical oral things. So again, the left is a very big ulcer. The other is almost perforated, a pseudocornea. You touch in the periphery in the second one. In the first one, you do a good cauterization. Just that you don't have to touch the conjunctiva, otherwise there's pain to the patient, but else you can very thoroughly cauterize. Of course, when it is perforated, just do the periphery. The acid would not go inside at any point of time. And the eyes are usually salvaged in such cases. So we are majorly talking about the fungal and maybe a secondary bacterial infection. So post-carbolic acid cauterization will give a subconjunctival chloramphenicol, and atropine, antifungals are put, antibiotic, and we do pad and bandage, and we do this regularly for about a week or 2 weeks or 3 weeks till it heals. And it, believe me, it responds very well when it is not responding to other measures. Thank you so much.
Sir, you have shown that you are using a matchstick to apply. Isn't it dangerous? I mean, you are treating an ulcer, and then you You are also scraping with the
Yeah,
wooden thing.
so that is the most important thing. I mean, only if it is not, the cornea is not very thin. Otherwise, usually stroma is pretty, it's quite tense, and you thoroughly do it. That is the important thing, so that it penetrates a little deeply, and nothing actually happens. Nothing happens unless it is very thin. Only the descemetes and the endothelium is there. Most of the times, it is pretty thick, and nothing will happen actually. It will not perforate by carbolic actually. It never does.
And in cases, that one case you are showing desmetocele is there and the periphery you are applying.
Only the periphery.
So do you use glue and BCL above, over and above?
Yeah, over that it can be done. But most of the times we'll just, that is just a rare exception that we might touch a little if it is too thick in the periphery. Otherwise, those cases are of course for therapeutic PK or glue, but most of the other cases, these will be done by carbolic, and actually it works very well. Nothing happens to the cornea, it will never perforate actually. It's a pure carbolic acid, but it never perforates actually. Pardon? It is pure carbolic, 100%. Pure carbolic.
And you need to repeat it once or twice?
So no,
Only
just
once.
do it thoroughly. We see the difference if you don't do it very thoroughly. It tends to, the healing is delayed actually. And you do it very thoroughly, it heals so early that we've seen practically actually.
Thank you, sir.